Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from South Korea, Dr. Jason Park. Dr. Park is a clinical associate professor at the Seoul St. Mary's Hospital, the Catholic University of Korea, Seoul. He did his fellowship in neuro-oncology and skull-based surgery at the Seoul St. Mary's Hospital College of Medicine, and his clinical interests are focused on minimally invasive skull-based surgery. He is an invited faculty for several world-renowned endoscopic courses around the world, and he is also a noted author with several publications in various peer-reviewed journals. We are extremely honored and grateful to him for accepting our invitation to be a speaker for today's webinar, and today we'll be talking about his experience of being a skull-based surgeon. The speaker for the second session of today's webinar is our honorable faculty from China, Professor Ming Sheng. Dr. Shen is a clinical associate professor at the Huashan Hospital, Fudan University, Shanghai, China. He was a visiting scholar of the University of Pittsburgh Medical Center and Pacific Neuroscience Institute in Los Angeles. He has the distinction of being a champion 3 times in the pituitary endoscopic skull-based surgery competition of China's young and middle-aged neurosurgeons, and he is also ranked among the top 10 brain tumor and skull-based in 2023 nationwide competition of diagnosis and treatment of capability of Chinese neurosurgeons. We are extremely honored to have him today at our webinars, and today we'll be talking about endoscopic endonasal contralateral transmaxillary approach to the lateral skull base. The chair for the first session of today's webinar is our honorable faculty from Japan, Professor Takuya Goto. Professor Goto is a chairman and professor of neurosurgery at the Osaka Metropolitan University Graduate School of Medicine, Osaka, Japan. He is a world-renowned endoscopic skull-based surgeon, and he is an invited faculty to several workshops and conferences around the world. He is the co-chairman of the Neuroendoscopy Committee of the World Federation of Neurosurgical Societies. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is another leading star in skull-based surgery, Dr. Calvin Mack. Dr. Calvin is a consultant neurosurgeon at the Queen Elizabeth Hospital, Hong Kong. He is also a clinical associate professor in the Department of Neurosurgery, Chinese University of Hong Kong. He is the secretary of Hong Kong Neurosurgical Society and the vice president of the Hong Kong Neuro-Oncological Society. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Prof. Takuya Goto.
Good evening or good night. I'm today very happy and feel very honored to chair this good session. Today, the first speaker is Professor Jason Park. He's already, one of the very famous active, less invasive skull-based surgeon in Korea and also in the world. Last year, I attended the Korean skull-based meeting, and I found out the quality of the Korean skull-based society is very nice. So today, I am very, very happy and interested with his talk. Today, his topic is journey of skull-based surgeon. So I want to listen his lecture. So please, Jason Park, please start the lecture.
Okay, thank you for your introduction. I will quickly share my slide. Okay, well, first of all, thank you for your very kind and generous introduction, Professor Goto. I am honored. Hello, everyone. My name is Jason Park, and I treat brain tumor patients in our university hospital. I would like to express my gratitude to Dr. Raja Keikuri for inviting me, and I appreciate all the hard work that ACNS is putting through for the future generation. I feel honored to be a part of this great project led by President Yoko Kato, and I will try my best to contribute. So when I looked into the ACNS webinar page, I was surprised that there were already more than 400 videos uploaded. Many familiar names were already there, representing their special achievements in the field. So I thought that adding something similar would not help that much for the audience that I was told would be the neurosurgeons in the younger generation. I have no conflict of interest to disclose, but I would like to state that I'm not talking as a master of skull-base surgery, such as the chair, Professor Takeo Goto, but I will be talking as someone that is just a few steps ahead from the audience, probably still in their residency or their fellowship. So I intend to focus more on the treatment strategy that I have been applying to myself over the years. My university is called the Catholic University of Korea, and we are composed of 8 university hospitals. They are mostly situated around the capital city, Seoul, and altogether it's called the Catholic Medical Center. We are the largest hospital network in Korea, and approximately 10% of the neurosurgeons in the nation are trained in our institution. I am currently working at Seoul St. Mary's Hospital, which was renewed and expanded from the previously known Gangnam St. Mary's Hospital in 2009. And at that time, it was the 5th largest hospital in Korea. I was trained by these 2 leaders of the Korean neurosurgical societies and finished my 2 years of fellowship for neuro-oncological and skull-base surgery. What many people do not know is that these 2 were one of the pioneers of endoscopic intranasal surgery in Korea. They started doing it early around 2005, and they even went to the Pittsburgh course together. They were strongly opposed by the previous microscopic neurosurgeons and criticized multiple times. Naturally, I was exposed to endoscopic intranasal surgeries early in my residency and followed on that path. In today's talk, I will discuss about 3 factors that I feel necessary and important in becoming a skull-base surgeon. I will share you about a very special patient of mine that can be an unfortunate story. But however, treating this patient has taught me immensely, and I think it shaped the surgeon that I am for now. So my first encounter with this patient was 2016, when I was in my 2nd year of fellowship. So she was taken care under my professor. She underwent open craniotomy 5 years ago, and the diagnosis was atypical meningioma. Most of the tumor was removed, but with a little bit of remnant mass at the cavernous sinus. So they did further radiation of 54 gray for that cavernous sinus lesion. She was clinically stable, but this extracranial tumor was gradually progressing, including the cavernous sinus. It was progressing into the nasal cavity. Around that time, we had an opportunity to invite Dr. Jana Kiram, who was not a neurosurgeon, but a skull-base surgeon from India, to hold a workshop for ourselves. So this is a photo of me and Dr. Jana Kiram, and he brought an assistant with him, and he was doing lectures and prosection for the group of people in my institution. The course started with the half-day lecture and 2 following consecutive days of hands-on workshop. And this was the first time I was introduced to the extension to the coronal plane, which included the transpterygoid approach. And the patient I just mentioned was decided to be treated with this approach. So here will be the video for the transpterygoid approach. And the surgery started by our ENT colleague that he is now making the nasal septal flap. And after that, we will enter the maxillary sinus. So here we can see the posterior wall of the maxillary sinus, which would be the anterior border of the pterygoparietal fossa. And as we are opening it, we can see the fat tissue inside, and we will be identifying the vessels and nerves inside, and we place the clip on the internal maxillary artery to prevent further bleeding from the tumor. And then when the tumor was exposed, I went inside. I went around the tumor to remove all the bony tissue. And I already knew from the preoperative MRI that the tumor will be in front of the cavernous carotid ICA. So I was it was pretty okay and safe to do all these bone work. And when we look at behind the tumor, we could see the margin was pretty clear. And this remaining sphenoparietal artery was coagulated and incised. And then when we further dissect the tumor, you can see that here's the bone in front of the paraclavicular carotid, and this is a tumor. And we could see an opening to the cavernous sinus over here, which would be the extension to the tumor from the cavernous sinus to the nasal cavity. So we didn't actually go inside this time. We just put some surgery cells in then, and we removed the rest of the tumor by expanding the bony opening and removing the rest of the tumor. So I will skip this area. And at the finishing of the surgery, so we can see that most of the tumors are gone. And this was actually the first transpterygoid approach performed in our hospital. And the workshop we just participated greatly helped, and understanding the anatomy was very important. So this on the post-operative MRI, you can see that most of the tumor was removed except for the cavernous sinus lesion. And because she already had a round of radiation, we didn't go for another round of radiation at that time, and we just did careful observation. So here comes the first quality I would like to talk to be the surgical education. So knowing and understanding the anatomy is crucial in performing skull-based surgeries. The more you know, the more you can do, and the surgery will be more safe and efficient. So we need to be prepared by training and practicing before we actually start treating patients. Other than my fellowship training, I have participated in various difficult courses to train myself. The first one was more about routine transsphenoidal surgery, and the second one here was about open skull-based approaches. And after this third workshop I participated, I could do the transpterygoid approach. And even after the surgery, I figured that more training was necessary, and I participated to 2 more other endoscopic skull-based courses to train myself. The first one was the workshop done by KOSEN, which is short for the Korean Society for Endoscopic Neurosurgery, and I went to the Pittsburgh course. So if I show you a recent case, this is a case about a year ago. So it's a bony mass. Patient was a 50-year-old female that presented with nasal congestion. She had a history of nasal surgery 5 years ago and was told that the lesion was suggested as a nasal chondroma. From the preoperative imaging, we can see a lesion involving the right pterygoparietal fossa and extended into the nasal cavity and the lateral recesses of the sphenoid sinus. I assumed that this could be a chondrosarcoma, and I planned for a transpterygoid approach. This study video starts after the exposure, and since this lesion was clearly a bone tumor, you can see the abnormal tissues that are involving the bone. So you can see all the abnormal looking bone here, and I am dissecting and removing the tumor until I can find the normal bone margin. Probably because the patient was already operated once, the anatomy was a little bit distorted. But however, since I was much more familiar with the anatomy, it was not really a problem to remove all the tumor. Her pathologic report turned out to be a grade 2 chondrosarcoma, and without radiation, I am observing her a year now with no evidence of recurrence. So it was done without that much of a problem. And here is the follow-up MRI with no evidence of recurrence. This understanding of the anatomy is not something that just happens in daily clinical activities, because we do not get to see enough of these patients to get used to it. So the first thing I try to do is having this mini workshops. I gathered a small group of people, collected money together to buy a cadaver to practice and teach ourselves. This was very helpful to learn, but there was a financial burden to collect that money every time. Meanwhile, I was able to participate in several workshops as lecturer or faculty, which offered me the privilege to teach other people. And the next thing I started to do is teaching residents and medical students. So I do this a lot of times in Korea. And the reason I was doing all these activities was because I found out that teaching somebody else is the best way to learn. So for those who are interested in skull-based training, I strongly recommend that you teach someone you can, and if possible, participate in these kind of workshops. Back to the patient, she underwent several additional last debulking surgeries afterwards, and the lesion was quite manageable for a couple of years. However, this extension to the infratemporal fossa was progressing, and I participated as redo transpericord approach was planned. But in this surgery, the lesion was too lateral and inferior that we could see the lesion but could not reach the tumor properly. Moreover, the boundaries between the tumor and pterygoid muscles were unclear. And partial resection was the best we could do at that time, and further radiation was given for palliation. So for more than 2 years, the patient's tumor was stable. My mentor, who was in charge of the patient, retired from our hospital, and the patient was now under my care. The remaining tumor started regrowing someday, and I was wondering what I should do and when I should intervene and something like that. And I was pretty sure that doing normal things would inevitably fail to properly remove the tumor. And I also thought that not removing the tumor in whole would be the part of the problem. It is repeatedly relapsing. And here comes the second quality, collaboration. I decided to do a combined approach coming from above and below, and plan to do collaboration with my colleagues. So since this was something that had never been attempted before at our institution, I needed to plan carefully. Coming from above, Professor Kunjon Kim from the Head and Neck Division participated for the transzygomatic approach to the infratemporal fossa. And Professor Do-Young Kim from the Rhinology Division performed the extended transmaxillary approach. It is basically a transpterygoid plus caudal look operation so that we can reach more inferior and lateral, because we have this experience that failed to resect all the tumor with just a transpterygoid approach. And for reconstruction, I plan to do a multi-layered reconstruction, including the fat graft. And I didn't plan to use vascular tissue at the time because the surgery was planned to be done in a totally extradural fashion. CSF diversion with lumbar drain was something for an option I could use in case of CSF leakage from some sort of a defect. I actually made a group chatting room together about 1 month before the surgery and had everybody involved together, including the scrub nurse, to prepare for the surgery. So this was the view from the above after the approach by my head and neck partner. And here you can see the eyes over here, ears in the back over here, the area where the zygomatic arch usually situated. And the tumor was pretty easily exposed, but the anatomy was completely gone because of multiple surgeries and radiation and all that. There was no finding the correct anatomy, so I was relying on the navigation with integrated with the microscope, and I could see that the bony floor of the middle fossa was completely infiltrated by the tumor. So I was carefully dissecting and removing all the abnormal looking tissues, and finally I could see some kind of a something that resembles like a nerve. And I thought that might be the mandibular nerve, and preserved it. So this was like almost the end of the transcranial part, and we will look from below. So this is after the caudal look operation. You can see the upper teeth, gum, and the hole on the anterior aspect of the maxillary sinus. So we can further expand this hole to get inside the maxillary sinus from more lateral anterior route compared to the endonasal route. So here is my colleague doing one-handed surgery, and I joined after this is the patty we cut it from above. So the two fields are connected now. And when I removed the bone that was covering the previous defect in front of the cavernous sinus, I could see where the tumor was over here. So this is all the tumor. And now I have reached the tumor, so I was trying to remove it as much as I can. And since the margin was very unclear, it was pretty difficult to determine how much tumor I have got removed. So I really try to do my best to remove everything that is looking abnormal, trimming it out with scissors and coagulating. And to make some sort of a margin here, I did several sutures over here, and then the defect was in the defect some fat tissue was inserted to cover the dead space. And this would be the post-operative image, and you can see in the MRI that most of the tumor were removed, except for the cavernous sinus lesion over here. I was watching her carefully at my outpatient clinic, and initially she was fine. However, after 2 months later, CSF rhinorrhea occurred. So from the first transcranial approach, the temporal dura was not very intact. It was somewhat very weak. And because of that, I did some dural onlay for reinforcement, but I guess that wasn't enough. So this was happened inside the nose, that there was a defect over there because the fat there was gone, and she had CSF rhinorrhea. So to fix this complication, I collaborated with Professor Seok Moon from plastic surgery, and we applied an anterolateral thigh reflap for reconstruction. And I suppose this may be the thing I should have done in the first place. So these are all, I think, good examples of collaboration, and I truly believe that collaboration makes things better. And other example of collaboration I am doing is with my neurotology partner, Professor Jae-Yeon Seo. So this is a trans-lab approach case. The patient was observed many years in the ENT outpatient clinic, and finally she had lost her serviceable hearing, and the tumor was continuing to grow, so that they decided to do a tumor removal by this translaborative approach, and she was consulted to me. So we did the surgery together. And this is the surgical view after the mastoidectomy. This is the left side of the patient. We can see the EAC, the posterior fossa dura, and my neurotology partner did all the bone work, and he had exposed the IAC, the tumor inside the IAC. So after that, I am inside to open the dura, and then I could see the tumor inside. So first I checked for the facial nerve, trying to do subperineural dissection to stay inside the perineum of the vestibular nerve. And here I could see the vestibular nerve. And on the superior anterior side, I could find the facial nerve. So here's the facial nerve over here. And I could confirm it with the stimulator. And I carefully, leaving perineum on the margin, I'm slowly removing the tumor little bit by little bit, and trimming down the tumor to make it smaller by scissors, not using sonopad or something like that, ultrasonic aspirator. And then later on, I could see this nerve vesicle that seems to be involved in the tumor, and I could cut it, and then further dissection is done. And this would be almost at the end of the surgery, that the tumor was completely dissected and removed. So I did a couple stitches on the dura, covered with taco seal, and the dura substitute as an onlay. And my ENT partner will come in and inside and close the wound with some fat graft inside, and they covered it with titanium plates. So in the post-operative image, the tumor was completely gone, and she was happy because she had no facial palsy. She even told me that she could hear better, which was obviously not true. Anyway, she was happy and was discharged in a few days. And for this collaboration, I would say that even though we don't do surgery together, we can still collaborate. So this is another patient that was referred by my neurotology partner. The patient went to the ENT clinic because he couldn't hear. Because obviously, people go to ENT when they can't hear, they don't come to neurosurgery. So they did an MRI, then they saw this cystic tumor, which presumably should be the vestibular schwannoma. And because the patient still had hearing and it kind of decreased pretty abruptly in the near just a few like weeks ago, I was planning to do a hearing preservation surgery. So this is after the opening of the dura with retrosigmoid approach. I don't usually put fixed retractors because I don't feel it's necessary. Just proper positioning and sufficient CSF drainage is usually enough. And I am sending some tumor tissue for frozen biopsy. And here, after identifying the tubing line, I'm drilling out the posterior wall of the IAC to expose it. And then I will be opening the dura of the IAC. And I open the dura. And I will do intermittent stimulation to locate the facial nerve. And I'm trying to do subperineal dissection as much as I can to try to preserve his cochlear nerve. So this is almost done by, most of the tumor is gone. And at the post-operative image, there is some thin capsule around the brainstem over here, but I would say most of the tumor is gone. And this patient actually got better hearing after the surgery. So, and I am just following him up in the outpatient clinic, and he's still happy. So, well, these kind of things are, I think, the very good examples of collaboration, and I would strongly suggest that you will collaborate with the people around you, that they can very much help with your surgeries and your life also. And returning to the patient story, the flap we have done with the plastic surgery department has failed multiple times. And I thought that was probably due to previous history of multiple surgeries and radiation. And the patient needed redo flaps like twice more. And it took a lot of time until she was properly healed. And we were doing intermittent MR exams for the patient, but there was a little bit of tumor recurring around the orbit. And after a year, when finally she was okay, this was the exam. The tumor was like very big, something like a sphenoorbital meningioma, but since there were already no bone over there, it was just tumor mass completely filling the previous defect. And well, and the last is to come with innovation. So the most familiar innovation in the skull-based surgery field would be the introduction of endoscopic endonasal surgeries. It was introduced by Professor Haedong Zhou and Rick Corral, but I believe that Professor Amin Kassam and his Pittsburgh team truly pioneered the field. Well, we recently invited him to our workshop, and we spent very valuable and inspiring time together. More recent form of innovation would be the transorbital approach. It was started by Chris Moe from US and Darley Dubé from South Africa, and the approach became more and more popular as doctors from Italy, Spain, Korea, and more people got involved and shown interest in it. I have been close to the pioneers of TOA in Korea, naturally learning how and when to utilize it. So, well, the patient was going through a lot, and I didn't really want to open up one of the previous wounds of her. And since I was lucky enough to know how to do this approach, I told the patient that we wouldn't have this approach. If it was like 5 or 10 years ago, but now we have this innovative new approach that can use another corridor to remove your tumor. And so this would be the transorbital approach for the patient. This is her right eye. And here we can see her lateral orbital rim. And this is me looking from above. And this is the microscopic view because since it is pretty superficial, I don't really need an endoscope to put inside. There's no place to get inside. So I did the opening part and most of the part that comes first with the microscope. So I could dissect inside the orbit. Here's the tumor already. And I removed the orbital rim and the tumor just there, just sitting to get, they removed it. So it was not very difficult, but it was very sticky and adherent to the surrounding tissues. So that was the problem. And the other thing was I didn't really want to violate the previous flap because we spent very hard time to make it work. And the tumor that was stuck to the orbit was another thing that was very tight and adherent that it wasn't very coming up that easily. So the surgery itself was just removing the tumor, identifying it. So I will skip most of it. And then later on, when it gets deeper, when it gets deeper, I will put in the endoscope to see inside, to look around the corners, trying to dissect most of the tumor as much as I can. So, but we had a little bit of violation to the nasal cavity, so we needed to fix it in some way. So using the endoscope, we tried to remove most of the tumor as much as we could. And this would be the end of the surgery. So we did the maximal debulking surgery because we didn't want to violate the previous flap. And the other thing was she was now diagnosed as an anaplastic meningioma. So we decided to do further radiation. And she is not happy, obviously, but she is still managing. And the tumor is relatively stable for now, but we never know how long that's going to last. So this is the story of the patient. And well, I'm not sure that I made a very an excellent job of it, but we tried my best. And on the process, I learned very much and a lot about how these kind of skull-based lesions should be treated. So my take-home message will be that first you should educate and train yourself. You will need the anatomic knowledge for the basis of your practice. The second thing you should do is build a team that you can work together because collaboration is powerful. And the third thing is you should always seek for better options, and you have to develop one if there is none. That was how this area has progressed until now. And thank you for listening, and this will be the end of my talk. Thank you very much.
Thank you, Dr. Park. I'm very impressed your very good detailed step to be the good skull-based surgeon. I have the one question. You show the three surgical approach. One is endoscopic endonasal skull-based, and then you show the microscopic transcranial approach, and finally you show the endoscopic keyhole approach. So to be the skull-based surgeon, we have to master the many approach, microscopic approach and endoscopic approach. So do you have some message to young doctor how to learn the two approach, microscopic surgery and endoscopic surgery at the same time, or at first it's better to learn microscopic surgery and then move to endoscopic approach? Do you have some comment?
Well, that is a very good comment. I think about it a lot, but even in my generation, we were trained as microsurgical surgeons first. So, and we are also taught that even if you use the endoscope, you have to use the same principle as in microscopic surgery. So for instance, when I do a pituitary adenoma surgery, I don't use curettes. I always make enough exposure. I dissect, I never pull. I dissect, cut, and remove. So that was like the principle of the microscopic surgery. So I think at least we should like know that kind of a principle first. And afterwards, I would say if the situation allows, I think it can be more easier to focus on like one kind of approach or one kind of a disease category because it makes the learning curve shorter. I had to do everything by myself, so I needed to train for a lot of things at the same time, and that is surely taking a long time. But the bright side, it gives you some kind of a comprehensive understanding of the anatomy. So it helps in that way, but it's a very difficult task, I think. That's what I think, yes.
Okay, thank you. Is there any question or comment from the audience?
Surely, I would like to comment because this has been a very exciting talk, and I'm really grateful to Dr. Park for coming here and showing how he started his career. I'm extremely impressed. As a viewpoint of my young neurosurgeon, on behalf of others, I would like to ask that early in the career, if you have a devastating vascular injury as a complications, I don't know if you have had it. What would you recommend when you have it in earlier part of your career?
Well, I do have some vascular complications, and in that case, my vascular colleagues were very helpful. Well, so I think we should be more prepared on those kind of more dangerous looking tumors when we are planning it. And even though when we are very cautious and careful about it, it still happens. So, well, most of the times it was managed by endovascular treatments, but sometimes it's better to fix it in an open approach. But I think that's something that's very difficult for the younger generation because it's not very easy to handle it and make it like better. And in those cases, I would suggest that you should get some help for your superiors because the people who have more experience will have some other measures that can tell you what to do.
Thank you very much. Yes, my co-host Liubun Seng, any comments from you?
Thanks, Raja, and thanks, Professor Park, for a very nice lecture. I have a 3 short question, Professor. My first question, Professor, when you use tissue glue, do you find that the effectiveness of the tissue glue would be worse after applying a Surgicel? That's my personal experience. If I use Surgicel, I find the effectiveness for proper dura sealing is less than without Surgicel there on top. My second question, Professor, and now become a very, I think, important trend, I think especially in among Japanese neurosurgeons, is to do a dura suturing. That from their opinion is the best to reduce CSF leakage, which are the main complication of a skull-based surgery. What is your experience and opinion regarding this? And my last question, Professor, regarding malignant skull-based tumor, do you have any experience using fluorescence, such as 5-ALA, for those cases in helping you to demarcate the tumor margin? Thank you, Professor.
Okay, so the first question was about Surgicel and glue.
Yes, sure.
And for me, the glue is something to make things just like stay that way. I don't really trust glue as a sealant. So in order to somehow fix the leakage or something like that, I don't really rely on glue. It's some kind of a supplementary method for me. So I would do other things and then maybe little help of glue to try to make things like stay that way for just maybe for a little while. And actually the Pittsburgh group, they told me that they did do some kind of a RCT that if the glue helps or not, and they were concluded that it doesn't help, so they're not using it at all. And about the second question, dural suture, well, I know that my good friend, Japanese good friend, like Hasegawa, he is very good at dural suturing, but the dural suture with an endoscope is actually technically not easy. It requires some kind of expertise and experience. And for me, even though I do open craniotomy, I don't trust in watertight suture. How tight I suture the dura, it's gonna leak in some holes. And even with the needle hole, we suture with the needle, right? And the needle hole itself is a hole. So if something happens, it's gonna leak through that hole. And if you want to fix something, you need like 100% watertight sealing, which is never going to happen. So I know that dural suture is helpful, but I don't really seek for watertight suture. And when I do dural suture, it's more about like fixation and trying to make things like hold over there. Well, for example, for large anterior skull-base defect, I try to put some sutures if I can because I don't want the dural substitute to get stuck in the brain or something like that. So I try to make them stay in that area, and then using that, I will cover those defects with some other multi-layered fashion things to make that defect covered. So that was the second question. And the third question was, I don't really have experience of using 5-ALA on malignant skull-based cases because, well, for me, the malignant skull-based cases I will see are either bone tumors like chordomas or chondromas, or maybe it's some kind of something like olfactory neuroblastoma, something like that. But so for those cases, I don't really see the necessity of 5-ALA in that cases, so I never used it.
Thank you. Thank you very much, Professor.
Thank you. Thank you very much. Yes, Dr. Calvin is here. Would you like to comment, Calvin?
Yes. Well, hi, Jason. It's nice to see you here.
Great.
So, and so, yeah. So, from your opinion, there are different. You have beautifully demonstrated that there are different approaches for skull-based diseases, from open multi-team approaches to minimally invasive, for example, endoscopic transorbital or other endoscopic approaches. And so what would be your prediction for the trend? Would it be more, endoscopic multi-portal keyhole surgery in the future? Or it would be a trend for more open and collaborative multi-team operations? What would be your prediction in the coming future for the younger generation to learn, because they have to decide which type of skill or which type of collaboration they should go for?
Well, that's a very tough question, But anyway, if I would predict, well, I would say less can be better because you have to always think about the approach-related morbidities also. So, for instance, if you do a transpterical approach, we have to know the consequences. If you transect the median nerve, the patient's going to have dry eye. If you violate the greater palatine nerve, they're going to have some numbness in their upper cheek and something like that. So you have to know the consequences. So thinking of that, it's going to be better if you can do something in a less invasive way. But I also think about the main goal, which would be the removal of the tumor. So for example, for me, if there's some kind of tumor presented, what I think is, how am I going to get the tumor in the most proper way with making less morbidities to the patient as possible? But that's kind of a difficult thing to do. And well, I would say eventually you're going to have to study everything. But because the trend is going towards the less invasive procedures, I think that can be a strategic decision. to focus on the minimally invasive surgical techniques that can be more popular and they're going to be more well accepted to the population. But eventually, you're going to have to learn about all the anatomy and all those kind of aspects, so that makes you kind of more to the perfection, I guess. Something like that. I think Takeo Goto can say more about these kind of questions. What would you like to say?
Yes. Would you like to answer, Prof. Koto?
Yes. It's a very difficult to speculate the future in the skull-base surgery, but in my feeling, we need the whole procedure. For example, the petroclival meningioma or large vestibular schwannoma, we need microscopic open technique remains. But in some central skull-base tumor, of course, endoscopic NNS are very useful. And some paracellular tumor or petrous apex tumor can be resected keyhole endoscopic approach like the transorbital, or recently we developed the endoscopic keyhole anterior transpetrosal approach. It's also very useful. But so to treat the skull-base tumor, we need all we have to master all procedure. That's my impression.
Thank you.
Well, very well appreciated comments. So I think we had a very fruitful session from Jason Park, and now it's time we'll move on to the second session. But so I'll give this podium to my friend Calvin to take over as the chair and invite Prof. Ming Chen.
Yes, thank you. Thank you, Roger, for the invitation. And so it's my pleasure to introduce Professor Ming Chen to present on the quite interesting topic, I would say. It's a very interesting and useful approach, endoscopic endonasal contralateral transmaxillary approach, CTM, to the lateral skull base. So Professor Ming Chen, please.
Thank you. Good evening, Professor Raja, Professor Goto, Professor Park, and Professor Mai, and everyone. First of all, happy Lantern Festival. And this is Dr. Shen from Department of Neurosurgery, Huashan Hospital, Shanghai, China. It is my great honor to be invited here for the second time. Today, I'm going to talk about the combined endoscopic endonasal and contralateral transmaxillary approach to the lateral skull base. I have no conflict of interest to declare. And I come from Shanghai, a beautiful and modern city with 24 million citizens. We welcome everyone to visit us. And the Department of Neurosurgery at Huashan Hospital is one of the largest centers both in China and maybe around the world. We have over 130 neurosurgeons and performed 20,000 surgeries annually. We are also nominated as the National Center for Neurological Disorders of China. And myself was trained at UPMC and the Pacific Neuroscience Institute at John Wayne Cancer Institute in Los Angeles, two of the best endoscopic skull-base surgery centers in the US. And a dozen years ago, Dr. Loss advised against the use of transphenyl approach in several kinds of cellular tumors. The lateral skull-base extension is one of them. To traditional neurosurgeons, the ventral skull base is like the dark side of the moon that people are not familiar with. However, with the development of neuroendoscope, we are able to light up the moon from the other side. The midline structures such as the cellar, the planus sphenoidale, and the clivus can be approached with either a standard EEA or midline extended EEAs. However, the pyramidian structures such as the sphenolateral recess, the pterygopaladin, and infratemporal fossa are more difficult to approach. Sometimes require EMT approaches such as transesmoid, transmaxillary, transpterygoid approaches. Today, I want to talk about what we have been doing to treat lateral skull-base lesions via EEA for the recent years. The first part is the sphenolateral recess. This illustrative case demonstrates the endoscopic endonasal transpterygoid approach for the repairment of sphenolateral recess spinal fluid leak after previous unsuccessful transcranial surgery. The CT scan to the left demonstrates the Sternberg canal defect located below V2 and lateral to the Vidian canal. The MRI to the right delineated the encephalocele herniated through the Sternberg canal defect, causing CSF leak. And the surgical video nicely demonstrates the layer-by-layer surgical anatomy of the transpterygoid approach. The illustration to the right shows that the encephalocele and the skull base defect is covered by the pterygoid process of the sphenoid bone. The neurovascular structures in the pterygopalatine fossa, the upper part of the palatine bone, and the nasal mucosa respectively from deep to superficial. These structures need to be manipulated to gain full access to the pathology. Here is a surgical
This
video.
was a 53-year-old male presented with bone. Here we had finished the right side of the pedicle nasal septal flap.
This video has audio.
In the left nostril, the nasal septum was to the left, and the alcinate process and inferior turbinate was to the right. The alcinate process was resected, followed by asmodectomy to expose the maxillary sinus and the perpendicular plate of the palatine bone. Notice that the stump of the middle turbinate was preserved as a landmark. The mucosa of the lateral nasal wall was elevated towards the middle turbinate. Now the crista asmodalis of the palatine bone was identified as an important landmark to locate the sphenopalatine foramen running branches of the sphenopalatine artery. A callosan rongeur was used to resect the orbital process of the palatine bone to expose the pterygopalatine fossa. Now the sphenopalatine artery could be precisely sacrificed, avoiding postoperative epistaxis. After removing the stump of the middle turbinate and the surrounding mucosa, the sphenoid process of the palatine bone and the underlying palatovaginal canal was identified. The palatovaginal artery was coagulated and cut. The Vidian canal was identified. After sacrificing the Vidian nerve, the pterygopalatine fossa contents were further lateralized to expose the foramen rotundum. The base of the pterygoid process was extensively resected. Maximal exposure of the encephalocele in the spinolateral recess was achieved. The encephalocele was coagulated and resected under a 30-degree endoscope. The defect of the Sternberg canal was nicely exposed under direct visualization. Afterward, a tailored piece of septum bone was wedged underneath the defect to eliminate brain pulsation. A small piece of the fascia lata was used to cover the defect, followed by a second larger layer. The dead space of the spinolateral recess was filled with fat graft. The pedicle nasal septal flap was used as the final coverage. The postoperative course was uneventful. The patient's CSF rhinorrhea stopped immediately after surgery. He was free from complications and had no recurrence during the 1-year follow-up.
Okay, the second part is the pterygopalatine and infratemporal fossa. It is superficial to the sphenolateral recess, but is more complicated due to numerous neurovascular structures. The illustrative case 1 was a 45-year-old female presented with epistaxis and nasal congestion over 8 months. She has undergone surgical resection of cleidocordoma twice, followed by radiotherapy twice. The neuroimaging demonstrated the residual and recurrent tumor located at the right pterygopalatine and infratemporal fossa, as well as parapharyngeal space. The T2 image to the right showed that the long captus muscle and parapharyngeal ICA was located posterior to the tumor, and the temporal muscle and the lateral pterygoid muscle was located laterally. An endoscopic endonasal transmaxillary transpterygoid approach with medial maxillectomy was performed. A gross total resection was achieved. The image to the right shows the eustachian tube, the long captus muscle, and the lateral pterygoid muscle after tumor resection. The immediate postoperative MRI confirmed the gross total resection, axal and sagittal slice. However, severe epistaxis occurred before extubation, so we take her back to the OR again, trying to control the bleeding endoscopically. Active bleeding was identified in the parapharyngeal space. We tried to control the bleeding with bipolar, however, it did not work well. And the Doppler ultrasound detected the sound of active arterial bleeding. We were not sure if the bleeding was or was not from the parapharyngeal ICA. The curved bipolar was tried, but failed again. So we had to pack the bleeding, fight, and take her to the angiogram. The angiogram showed that the bleeding was from the dorsolingual artery, which was treated by onyx embolization. The third part is the petrous apex, which located posterolateral to the paraclival and petrous horizontal ICA. And EEA is suitable for petrous apex lesions if they project to the midline, but the posterolateral petrous apex is obstructed by the ICA during traditional EEA. And of course, transcranial approaches such as the middle fossa approach could be used. However, is there any more minimally invasive approaches? The caudal lock approach is used to treat diseases in the ipsilateral maxillary sinus by ENT for over 100 years. Recently, skull-based surgeons used the contralateral transmaxillary or the CTM approach to treat petrous apex lesions posterolateral to the paraclival and petrous horizontal ICA. The image to the right demonstrates that the trajectory of the CTM corridor is almost parallel to the petrous horizontal ICA, and these pictures show the surgical anatomy of the CTM approach. And this illustrative case was a 37-year-old male presented with left side diplopia for 1 month. He underwent transnasal surgery for clival-chordoma resection twice and gamma knife radial surgery once. The MRI with contrast showed the recurrent tumor was located at the left petrous apex, posterolateral to the ICA, compressing the brainstem. And there was also a second tumor nodule located at the suprasellar region with no compression of the optic apparatus, fortunately. A combined EEA and CTM approach was adopted for the petrous apex pathology. And here is the video.
The patient was a 30 vascular complications. We began approaches with resection of the right side uncinate process followed by asmodectomy and bilateral sphenoidotomies. Afterward, a right sublabial incision was made, extending from the right canine to the second molar. After soft tissue dissection, an anterior maxillotomy was performed from the dental alveolus inferiorly to the infraorbital nerve and foramen superiorly. After identifying landmarks in the maxillary sinus, an inside-out medial maxillectomy with resection of the posterior one-third of the inferior turbinate was performed. Afterward, the pterygopalatine fossa was opened. The sphenoidal sinus was entered afterward with a combined endoscopic anal-nasal and CTM multiport approaches. The residual middle clivus and the petrous apex were drilled to expose the left paraclival ICA, the foramen lacerum, and the tumor in the petrous apex. The two-section technique was adopted during the tumor resection. An ultrasonic bone curate was used for safer bony removal of the residual petrous apex, and the residual tumor was removed until the sixth cranial nerve in the Doralus canal was exposed and confirmed by EMG monitoring. Neuronavigation was used to confirm that CTM corridor had a 22 degrees advantage over traditional EEA, which was very helpful to manipulate tumors posterolateral to the paraclival ICA. There was no intraoperative CSF leakage after gross total resection. The tumor cavity was packed with an autologous fat, followed by a layer of fascia lata. The defect of the anterior maxillary wall was left open, and the sublabial incision was sutured with 4 absorbable interrupted sutures. The histological pathology confirmed the diagnosis of chordoma. During the 1-month follow-up, his symptom of diplopia improved significantly. The follow-up MRI confirmed the gross total resection of the target lesion with satisfied brainstem decompression. A proton beam therapy was arranged.
He was treated with proton beam therapy 6 months after surgery. During the 1-year post-proton follow-up, he had normal vision, normal eye movement, with slight diplopia gazing extremely to the left. MRI showed no recurrence. And so let's come back to the pterygopolitan and infratemporal fossa. Approaching from the front, we have to deal with branches of the imax might cause vascular injury difficult to deal with, just like the other case of chordoma. What if we add a CTM approach to gain access using the side door to avoid neurovascular structures in the pterygopolitan and infratemporal fossa? Second illustrative case was also a recurrent chordoma. The MRI demonstrated that the tumor involved multiple compartments, including the sphenoid sinus, the right pterygopolitan and infratemporal fossa, and the middle cranial fossa. The CT scan to the left showed erosion of the sphenoid bone, including the pterygoid process. The image to the middle showed the relatively normal pterygopolitan fossa, and the image to the right showed the branches of the right imax was located anterolateral to the tumor, favoring a CTM approach. And this is the video. The right middle turbinate was resected first, and the maxillary angiospermy with posterior medial maxillectomy was performed. And the posterior one half of the nasal septum was resected. After sublabial incision and soft tissue dissection, the left infraorbital foramen was identified by image guidance. Anterior maxillectomy was performed up to the infraorbital foramen. The posterior one half of the left inferior turbinate was resected, and the posterior medial maxillectomy was performed. The image guidance showed the trajectory of the CTM corridor to the pathology behind the pterygopolitan fossa, and the surgical freedom of the CTM corridor was satisfied. The tumor in the sphenoid sinus was removed first. And the orbital process of the right palatal bone was further resected to allow slight lateralization of the pterygopolitan fossa. The right side optic canal decompression was achieved, and the right foramen lacerum and surrounding landmarks were identified. Afterward, the parapharyngeal space was opened for further tumor removal. The eustachian tube was to the left, and the sphenoid-palatal artery was ligated. The CTM approach was added with 30-degree endoscope to resect the tumor in the most lateral aspect of the middle cranial fossa and infratemporal fossa. Here, the right V2 was identified and preserved. The tumor nodule invading the middle fossa was gently resected with curved suction. Here you can see that the CTM corridor was almost parallel to the long axis of the pterygopolitan fossa, favoring manipulation of the tumor nodule in the infratemporal fossa. A minor arterial bleeding from the temporal muscle and lateral pterygoid muscle was coagulated with angled bipolar delivered from the CTM corridor. And all anatomical landmarks of the lateral skull base were nicely identified after tumor removal. After switching back to a 0-degree endoscope in the lutein transnasal corridor, we can see that the preserved pterygopolitan fossa really obstructed our surgical corridor to the pathology. Postoperative MRI confirmed a near total resection. And the 6-week follow-up MRI revealed no recurrence with improved symptom. The last part is the inter- or subdural lateral skull base, including the lateral canal sinus, mesiotemporal lobe, and parapeduncular space. We call this area the retroclauded area of the canal sinus as the surrounding area. An endonasal lateral approach with ICM medial mobilization was suggested by Dr. Hong's team. However, the tight conjunction formed by the abducens nerve and infralateral trunk sometimes prevents the access to the retrocrotid area. As illustrated by this case, the tight conjunction would really induce a potential neurovascular injury. Of course, transcranial approaches such as the middle fossa approach could be used. However, is there any more minimally invasive approaches? Does the CTM approach has utility for lesions in the retrocrotid area of the cavernous sinus? How to select patients benefit from this approach? To my best knowledge, this has not been reported in literature. We performed an anatomical study using 6 fresh cadavers. Compared to the routine contralateral transnasal approach, the CTM corridor provided an approximately 1 centimeter shorter distance, 1/3 larger surgical exposure, and a 25-degree more parallel trajectory to the cavernous ICA. And we call this the extreme median approach, similar to the principle of the far lateral approach for ventral brainstem lesions. Given that the CTM approach is always combined with EEA, the surgical freedom of this combined approach is undoubtedly better than traditional EEA. Another question is how to select patients using preoperative images. In routine MRI, you can barely see the maxillary sinus and the pituitary tumor in the same slice. Our data showed that the mean angle of the ME line, which connects the center of the eye to the inner edge of the anterior genu of the cavernous ICA, was equal to the mean angle of the CTM approach. So the ME line can be used as a reference to guide patient selection for the CTM corridor. And this is the first illustrative case. A 70-year-old woman presented with visual deterioration for a year. Imaging revealed a large multilobular adenoma. A significant portion of the tumor was located posterolateral to the left ICA, including the bifurcation, and the long axis of the retrocrotid portion was noticed to be parallel to the ME line. And this is a 3D reconstruction showing the relationship of the tumor with the surrounding vessels and nerves. And we performed a combined EEA CTM approach. Here you can see the combined multi-port corridor provides better surgical exposure, angle of attack, and surgical freedom. And here is a surgical video.
This is the first illustrative case of combined endoscopic anal-nasal and contralateral transmaxillary approach for pituitary adenoma with significant lateral extension into the retrocrotid area of the cavernous sinus and beyond. It is important to note that the retrocrotid portion of the tumor was parallel to the mid-eye line, which guided the contralateral transmaxillary trajectory based on our anatomical study. Notice the close relationship between the tumor and the left uncus of the temporal lobe, the cerebral peduncle, and the posterior cerebral artery. The posterior third of the right inferior turbinate was resected. The uncinate process was removed to expose the maxillary sinus. The right-sided pedicle nasal septal flap was elevated. A reverse flap was created to cover the exposed cartilage, and the septal flap was put in the nasal pharynx. A right cardiac lock procedure was performed. Sublabial gingival sulcus incision, soft tissue dissection. The anterior maxillotomy was performed from the dental alveolus inferiorly to the infraorbital nerve and foramen superiorly. This provided a nice trajectory to the left lateral wing of the sphenoid bone, which had been invaded by the adenoma. During the surgery, we removed as much of the tumor as possible under direct visualization. The left optical canal was decompressed from above. From preoperative CT scan, we can see the left anterior clinical process was eroded. During surgery, we noticed that the optic strut was filled with tumor, which was removed with straight and curved suction to decompress the optical canal from below. After removing the infradiaphragmal portion of the tumor, we opened the ventral wall of the left cavernous sinus. The tumor was removed with gentle suction. We encountered a barrier created by the radial cavernous sinus. and cranial nerves along the lateral wall of the cavernous sinus, which obstructed the lateral approach to the retrocarotid area. Therefore, we returned to the medial approach to continue the tumor removal. But there was still a hidden tumor behind the surgical field. After adding the contralateral transmaxillary approach, the lateral portion of the retrocarotid area was nicely exposed under direct visualization. A branch of the meningo-hypophyseal trunk was coagulated and cut to ensure safe manipulation. Through the enlarged oculomotor triangle, we gained access to the proximal daughter tumor and removed it. After coagulating and cutting small vessels adherent to the arachnoid membrane, we could safely cut open the arachnoid membrane to identify a second distal daughter tumor. Two-suction technique was performed very gently to resect this distal daughter tumor. We carefully examined the lateral arachnoid membrane boundary to ensure a maximal safe resection, which was also verified by image guidance. Minor arterial bleeding could be easily coagulated using a parallel trajectory under direct visualization. The resection cavity was clear, indicating the growth or near total resection of the tumor. We kept the outer layer of the arachnoid membrane intact to avoid injury to the neurovascular structures. Hemostasis was achieved with hemostatic materials compression. Here you can see the advantage of exposure and angle of approach relative to the anterior genu of the cavernous internal carotid artery provided by the contralateral transmaxillary corridor. Multi-layer reconstruction was performed with fascia lata and pedicle-nasal septal flap. The sublabial incision was closed with 4 observable sutures. Postoperative imaging showed a very good resection of this tumor. Here you can see the comparison of pre- and postoperative imaging.
The patient came through the procedure well, and the improved visual function was achieved after operation with no ophthalmoplegia.
This is an
In conclusion, the CTM corridor is a minimally invasive approach that provides improved access with a more medial to lateral trajectory. It is a complementary corridor in EEA for treating Lat.Skull-based lesions posterolateral to neurovascular structures. The middle eye line can be used as a reference to guide patient selection for the CTM corridor to paracellular lesions. Of course, more cases and long-term outcomes are needed to be confirmed its effectiveness. This is all my presentation, and thanks for the invitation, and thanks for your attention. Thank you.
Thank you very much. It's a very nice presentation. Sorry, something happening to my camera, but it's okay. So maybe I start with a question first. So I actually like the idea of the middle eye line, which you've rightly pointed out that from the scan is usually we cannot really see the anterior sinus together with the intracranial structures. So have you compared that in the intraop navigation, the angle of attack, is it reliable? Because the reliability is very important for this kind of measurement. And also, do you have any experience in combining the CTM approach together with a transorbital approach? Because for the last indication they've mentioned, it is good for lesions that is lateral to cavernous sinus, which in actual fact for transorbital approach, it is I would say it's a rather more direct approach from the transorbital route to the lateral part of the cavernous sinus. So want to know your view on this. Thanks.
Thank you, Dr. Mai. Very good questions. And the first question is the ME line for the CTM approach. Yes, we have performed an anatomical study, and in the study we see that the ME line was just parallel to the trajectory of the CTM corridor very accidentally by the neural navigation. And in real surgery, we also compared this ME line with the image guidance, and actually they are very similar. These two lines are very similar. The surgical, real surgical trajectory and the ME line are very similar. So we think we can use this line as the reference for the patient selection. And the second question is the transorbital approach. This is a very new approach, mainly performed by the South Korea group and also in Hong Kong and in the US. And we are also trying to learn this approach, and we actually have just sent a fellow last year to the Korea cadaver course, and maybe we will try this new approach. So in now we have no certain kinds of experience to share, but I think yes, it's definitely a very good approach for the lateral skull base, especially the lateral cavernous sinus. Yes, I totally agree.
Thanks for the excellent summary and the answer. So I see a hand from Dr. Ajith. Please raise your question.
Yeah, it's a very nice presentation because when you approach the petrous apex and the petroclivals in controsis, contralateral maxillary approach gives a lot of room for removing the petrous apex lesions. My question is regarding, will you always do a transpterygoid exposure, that is extensive medial maxillectomy and maxillary antrostomy when you do a contralateral transmaxillary approach? Second question is, in your last case, the pituitary tumor is, if I'm wrong, correct me, I think it is in the posterior compartment and somewhere near the lacerum. So, translaceral approach is more appropriate than a contralateral transmaxillary approach. Okay, I think you got my question. Understood my question?
Very good question. For the first question, yes, we always do a maxillary antrostomy and to locate the foramen of the where the SPA comes from, and we ligate the SPA first and open the and resected a part of the orbital process of the palatine bone to mobilize the terrible palatine fossa, and then we identify the palatal vaginal artery, ligate it, and further lateralize the neurovascular structures to find the Vidian canal and Vidian nerve. And if it needed, we sacrifice the Vidian to full expose pterygoid process and perform the trans-pterygoid approach for paramedian pathologies. And the second question is, yes, this tumor is soft. It's a silent ACTH type tumor, but without Cushing's syndrome. And the tumor was soft. Yes, you can do a routine EEA to resect this tumor through the enlarged oculomotor triangle. You can use angled endoscope and angled instruments to resect tumor. But as you see in the what we have demonstrated in the video, if you come from the CTM corridor, that you can avoid the obstruction of the cavernous ICA and you can get a more better surgical exposure, and the manipulability of this surgery was better. You can safely dissect the branches of the ICA and coagulate it if it is needed. Then you can make a larger exposure for sharp dissection of the arachnoid membrane and do it more safely. This is what we think. Thank you.
Okay, I got your answer because you said that it's in the parapedicular region, parapedicular between the anchors and the brainstem region. That last tumor, last case you have shown. So going through your last case you have shown.
Yeah.
So my question is, quadrilateral transmaxillary approach usually approaches the petrosal process of the sphenoid bone, and below that is the petroclival synchondrosis. Can we go up to the oculomotor triangle, because the parapedicular space can be approached through the oculomotor triangle region?
Yes. The CTM approach is first demonstrated for the petrous apex, posterolateral to the paraclival ICA and the petrous apex. Yeah. But we think it is also suitable for paracellular lesions behind the cavernous ICA, and also through the oculomotor triangle. And because the maxillary sinus is below, actually it is below the nasal cavity, so the trajectory is even better for the upper layer pathologies, such as the paracellular lesion, and also if the tumor is breaking through the oculomotor triangle, going into the parapeduncular space.
Yes.
Yeah.
Really,
thank you.
really wonderful. Really wonderful.
Thank you.
We can take comments from Goto.
Thank you for a nice lecture. At first, how my understanding contralateral transmaxillary approach is very effective to the petrous apex region just behind the carotid artery. But this time you apply this approach to the region around cavernous sinus. I never operate such approach, but after listening to your lecture, I want to check the cadaver study, how we can get the surgical view. Anyway, the endoscopic endonasal or endoscopic keyhole approach was new approach. So to share the information and collaborate the cadaver study is very useful to improve our surgical skill. So today, thank you your lecture. Thank you.
Thank you very much.
Thank you.
Prof. Park.
So I have a question. So I am familiar with the approach, but I didn't really have the chance to do it myself. So this is out of curiosity. So what are the costs of doing this approach? What are the patients going to suffer after doing this? Because, well, even though it's minor, I still feel that as a doctor, when we're going to do the surgery, we have to know what's going to happen to the patient, because, well, we can pay the cost, but we still have to know about it. So that would be my one question. And the other one is, so I think, so CTM was supposedly designed to reach behind the paraclival carotid so that we can access the petrous apex relatively safely and without the need to mobilize the carotid. But nowadays, they are even mobilizing the carotid. So, well, I think the indication and limitations are very confusing in some way. So, can you make it a little bit more clear for the audience? What's the good indications, that the limitation, these cases that you should not do CTM or something? That can you give us some of those advices?
Thank you, Professor Park. Very good questions. And the first one is the CTM approach that you have make an anterior maxillotomy, that if the patient feel the cheek, they will feel the bone defect by themselves, but others can not see superficially. And you also have to make the posterior maybe 1/2 or 1/3 of the medial maxillectomy. So may cause some trauma to more trauma to the nasal cavity. And also, if the V2 of the ipsilateral side of the cardiac approach was injured, the patient maybe suffer from numbness of the V2 area. And this is for the first question. But other complications, I think we can avoid. And the second question is very good because every maybe new approach has cons and contraindications. And we just think if the pathology is not easy to deal with by traditional midline ventral approaches, and if the trajectory of the long axis of the pathology favors the CTM approach, maybe we will try adding the CTM. But if during the routine EEA we have already got all the lesions and or almost a near total resection was already achieved, we will not add the CTM. It just depends by cases. But for the preoperative planning, we will discuss with the patient that if the tumor we are not the resection degree we are not satisfied, we may add a CTM. We always discuss with the patient and their relatives. And actually, next Monday we will perform condyosarcoma of the paracellar area just behind the cavernous sinus. The tumor is very calcified, and we will try the combined EEA and the CTM approach, and hope for the best. We can treat it well. Thank you.
Thank you very much. I think we can conclude this session. We'll take the final remarks from Calvin.
Yes, thank you, Raja. So once again, a great presentation from Dr. Chen Ming and also from Professor Wang Yongfei. A great team as always, and great result actually. And it's very interesting for me as well to learn about the CTM approach that can approach the paracellar region. I've done a couple of cases to the petrous apex, but not to the paracellar lateral extension for tumors that extend through the oculomotor triangle. I think it would be nice also to explore that in cadaver. I will try that myself next week when I'm back to the hospital. So it's always great to have this kind of a webinar platform to share results and share experiences and to stimulate one another's progress in this kind of a skull-based approach. So thanks a lot.
Thank you very much. Indeed, it was a very fruitful session, and I'll close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both speakers of today, Professor Jason Park and Prof. Ming Sheng, as well as the chairs, Prof. Takeo Goto and Prof. Calvin Mack, for the time and support for the ACNS webinars. A very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And we have an update that there are around 540 people who have joined us live through all the channels of WeChat, YouTube and Zoom. A special thanks to my co-host Liu Bun Seng for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.